I'd like to welcome back Annika Reintam Blaser for her second talk. Thank you.
Thank you very much. So this time we talk about can we score the degree of GI dysfunction. Disclosures, again, only academic, but this time I did a lot of studies on GI, trying to score the GI, let's say. Already almost 30 years ago, when SOFA-score was developed, then people in the group developing the score said that GI function is important, but there is no objective clinically relevant definition, and that there should be a future definition, and it should grade the severity of the dysfunction. Of course, there are obvious problems. It's size and functions of GI tract. There are many functions, and actually the only thing that we look in clinical practice is motility, which is not a function but prerequisite to perform functions. And GI tract is really large, and we usually focus only on the first part of it in clinical practice. And there is no monitor, it's true, and there is no biomarker. But if we think about other SOFA subscores, then also for cardiovascular SOFA score, you put cardiac and vascular function together and actually use blood pressure or medications to treat the blood pressure, treat the hypertension. Whereas creatinine and bilirubin also do not fully reflect all the functions of the liver. So it's probably not possible to capture all the functions of the GI for scoring or monitor. If we look, then definitely one single symptom or sign of GI is not sufficient, because there might be a sign present but GI dysfunction not, or sign absent but GI dysfunction present. And this has important consequences on nutrition management, for example, and probably also the other management. And we showed also already quite some years ago that single symptom is not sufficient, but if the patient has 3 or more GI symptoms concomitantly, then it is associated with increased mortality in these patients. 2012, we proposed a grading which is descriptive. You go at bedside and you say, this patient has acute gastrointestinal injury, grade 1, grade 2, grade 3, or whatever. You look at the patient and you say it there. It doesn't include any granular data. And we also proposed that it could be primary acute gastrointestinal injury or secondary, and both ways it can also contribute to multiple organ dysfunction and systemic inflammatory response. And then to move further, we developed the gastrointestinal dysfunction score, which is actually quite similar or based on the acute gastrointestinal injury grading, but we tried to take it apart and make it possible to document single symptoms and calculate it together. And these are basically the symptoms that nurses are usually or commonly collecting at bedside. Then, of course, we are still many of these symptoms and signs are subjective. And then our recent project was Cosmogi, a Delphi consensus process, where we try to define as good as possible all these signs and symptoms that physicians use at bedside to say if this patient has paralysis or whatever. And this is a complex process, but we were very glad to have almost 200 participants at the end still for definitions. Patients were only involved in the beginning, in the first, but not for definitions phase. And we had several consensus meetings and agreed on definitions, on outcomes, or actually variables that need to be monitored in patients in the ICU, and how they are defined. And here on this slide, the complexity actually is conceptually shown. If you, for example, look, we included also clinical entities or syndromes like gastroparesis, and it can include vomiting or gastric residual volume. And vomiting and gastroparesis were both defined in the Cosmogi, and it was specifically done like this to have a broad overview and be able to analyze the data as good as possible at the end. And if you look at the next block, then GI paralysis can include all those parameters. The ones with black, we couldn't find any method or any biomarker or whatever, and they were at the end not considered essential outcomes in this Kosmogi process. And these down here could all be signs of the bowel ischemia. And if we now take even a bigger block together, then we can say that all this together, or any of these when combined with the others, could indicate intolerance to enteronutrition. That is also difficult to define and always a matter of debate. And then we also defined some treatments applied to treat intolerance to enteral nutrition, or to influence, let's say better. Sometimes it is suggested that you should or could define enteral feeding intolerance as percentage of the caloric target achieved. Let's say you didn't achieve 50% enterally, so the patient has enteral feeding intolerance. The problem is that to come there, you need to go through several definitions, actually. You need to define what is the target, and it is different for every day, and actually nobody knows exactly what is the target in the first period in the ICU. Then you need to define how you monitor signs of enteral feeding intolerance. Then you need to define triggers to reduce or stop enteral nutrition. Then you need to define triggers for interventions. Should we manage it somehow, and what the interventions are? Then you need to define triggers to restart or increase enteral nutrition again if you managed enteral feeding intolerance or whatever symptoms. And then at the end, you say you achieved or not the feeding or energy target. And then, obviously, if you only start from the end, the definition cannot be very accurate. But I would like to say that actually this is all monitoring of GI dysfunction. Maybe this enteral feeding intolerance is only disturbing us because we think that there might be an easy definition and one sign defining enteral feeding intolerance, whereas actually we should just agree that GI dysfunction is complex. And actually in all the cases you can just say you monitor GI dysfunction, and at the end enteral feeding intolerance, GI dysfunction in response to enteral nutrition. So if GI function gets worse when you apply enteral nutrition, then this is enteral feeding intolerance. And if we now think what do we do in clinical practice, a patient has a large gastric residual volume, we apply prokinetics, there will be less gastric residual volumes, and we will give more enteral nutrition. Or we solve it differently, there is large gastric residuals, we give post-pyloric feeding, GRV is still large but drained, and we still give more enteral nutrition now post-pylorically. But if this all results in diarrhea, abdominal distension, and intra-abdominal hypertension, then we didn't improve but worsened gastrointestinal dysfunction. So just giving the drugs or kind of managing enteral feeding intolerance with these methods is not good if we don't look what happens afterwards or what happens to the other parameters of GI tract. And there our pediatrician colleagues have published a nice paper where they show different trajectories of acute gastrointestinal injury grade, and they show that if the AGI stays high or increases, it's associated with increased mortality, whereas it is not so good to evaluate it only at admission, and it is insufficient to describe organ dysfunction only at admission. Now there was one quite recent study looking at gastrointestinal dysfunction score that I showed, and acute gastrointestinal injury. Actually, as said, quite similar thing. AGI is descriptive. GITS tried to make it as granulated as possible, but the principle is the same. And this is also what they showed. And they showed that GITS and AGI both are independent risk factors of 28-day mortality, if studied separately, of course. But they work comparably, so it's not a big difference which one you use. The GITS measured within the first 24 hours is not good or not sufficient to predict 28-day mortality. And here you see you use either GITS or either AGI and all the other factors except SOFA and GI function score fell out of this calculation. It was interesting that there was a letter, and maybe we have been understood wrong, because in the letter they wrote that GITS should be better as HEI, and now HEI should be evaluated by 2 independent physicians to score HEI and to score GITS, and then GITS should be better. But actually this is not the idea. If you have a physician at bedside, they can probably very well apply HEI. So it's not necessary that GITS is better than HEI if you are there and you evaluate it. The problem with HEI is that it is descriptive and you cannot use it on the database or in studies. So there, GITS should have should be better. Now, there are many reviews on the gut as a motor of multi-organ dysfunction syndrome, writing that it is often a first event in a cascade that culminates in multiple organ dysfunction syndrome, and it is a combination of factors that are involved, etc. So all these nice graphs are produced again and again, and there is a lot of thinking and a lot of work behind. However, everybody says that to document and report these clinical symptoms and signs that are actually not so complicated is not possible. It's too difficult. And no study, large nutrition study, reported this gastrointestinal symptoms, etc. So we don't have data to analyze because people don't document GI dysfunction. And large databases do not have these data available. But it is not possible to test any of these nice concepts if we don't have anything to measure with. And now we are working on validation of GITS, so gastrointestinal dysfunction score. We have 2,680 patients included, and now we are dealing with data cleaning, which is quite an interesting process because we already detected that we don't have a definition for parenteral nutrition that is unified in the world and also among our investigators. Most of people thought that it is 2 macronutrients that are needed to define parenteral nutrition, but some said also low percentage glucose should be considered as parenteral nutrition. So this is the next task, to agree on what is definition of parenteral nutrition, because how do you report outcomes if it's not defined? And we also see that to report SOFA scores, not including GI, but all the others, patient data management systems used in the hospital are unreliable. We are correcting these data heavily and X times. For example, anticipated Glasgow Coma Scale is often wrong. Urine output, if the patient stays, for example, 6 hours in the ICU on this very day, and urine output is 200 milliliters, then it is not calculated up to 24 hours. And also missing lab values are handled very differently between different hospitals. There are maybe some options to assess GI function. We already talked about clinical assessment. We will also look at treatment as indirect indicator. Scoring, we already mentioned. Biomarkers we don't have at the moment. Imaging techniques, yes, also included. But experimental research tools need some basis to start with, to compare something with. And if we would use nutrition intervention as a surrogate, then we also need to look at enteral nutrition reduced due to GI dysfunction, parenteral nutrition used because of GI dysfunction. So it also needs the clinical aspect. If we just document the nutrition, decided to I don't know, based on subjective something preferences, then it's difficult to use nutrition, which is documented in large databases, sometimes, also not well, but sometimes at least. So at the moment it's not possible and needs GI to be documented. And here a good example of testing a new tool, testing automated bowel sounds measurement, and and they showed difference here in non-acute gastrointestinal injury and with acute gastrointestinal injury patients. So you need something to compare any intervention or any tool to measure any effect of an intervention. So can we score the degree of GI dysfunction? Yes, but we need to accept that there is currently no biomarker, but we need to collect, we need to report and collect all the data and monitor to have the data available to to make improvement in the future, because we cannot develop better tools if we don't have any to start with. And the paradigm probably should should move from nutrition-focused management of GI to GI function-focused. So managing to get enteronutrition in does not mean that there is less GI dysfunction, and we should change our thinking. Thank you.
Thank you so much. We have a couple minutes for questions. While we wait for people to come up, I guess I have two questions for you. The first one is, how do you think about prevention of GI dysfunction along sort of the pathway that you described? Do you do anything sort of early on to prevent the development of GI dysfunction? And then the second one is, how do you use this on your daily practice in your ICU? How is this employed? Are you thinking about this for all patients?
Sorry, the second question I didn't...
How do you think about this every day for your patients? Is this something that you're thinking about every day as you see patients, and how are you acting on it?
Thank you. Yes, we do every day monitoring. Nurses really document all these parameters. Nurses document, and we try to look if it got worse or better. Prevention is very difficult, but I think that we should really look at the enteronutrition effect. I think this is important, and I think we often miss it and do it wrong, because we think that now it is good if we can put enteronutrition in post-pyloric tube, for example, and don't look at the other parameters. Mm-hmm. Prevention is difficult because we need sedative drugs and stuff that all influence GI motility, of course. Maybe giving less PPI would be something that would also help. But again, to show that any intervention, it doesn't matter which, or any monitoring works, we need something to start with.
Yeah. You need a way to measure, absolutely. Yeah. That's great, thank you. Other questions? If not, go ahead. Here, do you want to use the mic?
Is it erythromycin or something else?
Well, there are two, metoclopramide and erythromycin. What we use, combination may work better. But problem is really that you should then look if really GI function got better or GRV get less. So there is a big difference. It doesn't mean that GI function got better if there is less GRV, because there might be a problem beyond stomach.
Okay.
Okay, thank you. Thank you so much. We'll go to the next speaker here, Dr. Lioudmila. Thank you. Dr. Lioudmila Karnatovskaia from the Mayo Clinic. She's going to talk about the importance of the gut microbiome in critical illness.
Thank you so much, everyone, for being here, for people who organized this conference, for inviting me, and for the opportunity to stir the pot a little bit, hopefully. So I will discuss the role of microbiome in general health and in critical illness, and why is it important, and what are the consequences of its disruption, and perhaps what are the next steps. So when you guys think of what makes us human, do you think it's our cells? But if you look at it, only half of our cells in our body really belong to humans. The rest is bacterial and other stuff in us. If you think it's our genes that make us human, well, I have news for you. For about 20,000 human genes, we have about 2 million bacterial genes. So genetically, we're only 1% human. So really, we're basically a walking ecosystem. So for the purposes of this talk, I will refer to microbiome as bacterial microbiome, but there's a whole host of other things, archaea, there's fungi, and all kinds of other stuff. So basically, our microbiome is very, very dynamic throughout the lifespan. It increases in diversity until about the age of 12. It's fairly stable throughout the lifespan, and then it decreases in diversity as we age. And over 35 species have been isolated in our guts. Most of them are commensal anaerobes. And most of the bacteria in our gut is friendly to us. They modulate our immune system. If you remember, more than 70% of our immune system is in our gut. They protect us from the pathogens, they synthesize vitamins, they determine our medication reactions, how we respond to drugs, our insulin sensitivity, they factor in our metabolism, and they ferment the fiber, producing short-chain fatty acids, which are your friends because they determine your inflammation, they basically degrade harmful environmental compounds, they promote the gut-brain barrier integrity, and they facilitate expression of enzymes that produce serotonin, dopamine, norepinephrine. They play a major role in our metabolism and cardiovascular health by modulating glucose tolerance, insulin resistance. They work in our immune function by determine whether or not we develop autoimmune disease. It all has to do with our gut biome health. And they also have anti-neoplastic properties. When they looked at how people age and stay very healthy, well, people who live to very long age and are healthy have very diverse gut biomes. Even when they took people out of the longevity area and they looked at the centenarians and they compared them to youth from non-longevity area, the centenarians had more diverse gut microbiome. But what happens as we live in our current society, that with our industrialized care, with our food that is processed and shelf-stable and sterilized, with the antibiotic use, with all the sanitation practices that we constantly squirting all these things on our skin in our hospitals and use antibacterial products in our homes, and other influence as well, our biomes are not as diverse as they probably could be. And it's been linked to most of the chronic diseases. There's gut everything access nowadays, gut brain, gut lung, gut, you think of it, and there is one. So you wonder, so what does that have to do with critical illness? Well, a lot of the things in the ICU, besides the illness itself, further disrupt our gut microbiome. Basically, within the first 6 hours of admission, we lose 90% of diversity of our gut microbiome, which in terms leads to proliferation of harmful bacteria, and that, coupled with inflammatory cytokines, leads to hyperpermeability, translocation of bacteria, dysregulation of immune system, more inflammation, and enhanced apoptosis. So all of that, the imbalance of microorganisms in the microbiome, is called dysbiosis. And how is it relevant to us as providers? This talk is just to make you think of things that we do in practice of our care. Antibiotic use, of course, everybody understands that it's really relevant and it reduces the microbial diversity. That's probably hardly any news. However, what type of antibiotic you use could be relevant, because we often think, oh, the broader spectrum, the better. But in a recent study of VAP patients, they looked at initiation of antibiotics with anaerobic coverage, which is technically you're not supposed to use for VAP patients, and they noticed an independent association with increased mortality in people who received anaerobic antibiotics. They postulated it because it destroys the commensal gut bacteria. So many times you think of throwing Zosyn at somebody, just because I often challenge my residents to give me a good indication. PPIs, Annika made a huge point about them, and I fully support her. They really do reduce diversity, which leads to promotion of enterococcal species growth, E. coli, and overall prolonged use does increase the risk of C. diff infection. Opioids also are not benign. They induce epithelial gut barrier dysfunction, they promote the growth of gram-positive bacteria, and they promote dysmotility, which in turn leads to bacterial overgrowth, decreased nutrient absorption, increased translocation of bacteria, and inflammation, which further promotes dysbiosis. We think bowel regimen, that's a beautiful thing for everybody, right? But it also is associated with decreased microbial density, decreased beneficial bacteria, so they produce less short-chain fatty acids. And when they did a study on mice, giving them PEG in their drinking water for 6 days, well, the green thing that you see here is the mucosal lining. It's supposed to be nice and thick. So the red stuff is the intestinal lumen. And after day 6, you see the lining is very, very thin. So it's not as benign as you may think. Antipsychotics also has been independently linked to diversity, decrease in microbiome. Steroids, not really many studies on human, very challenging data to obtain in isolation, but they do seem to increase bacterial translocation and impaired killing of translocated E. coli. They've actually done some study on fish, and they treated them with steroids, and then they looked at the biomes, and they found that the biome composition of young fish treated with steroids was that very similar of senescent adults. Nutrition is a whole separate ballgame because oftentimes it contains carboxymethylcelluloid used as an emulsifier. Well, it's pretty harmful to our gut bacteria. It decreases the production of short-chain fatty acid. It leads to decrease in microbiome diversity. It increases the levels of bioactive lipopolysaccharides and promotes intestinal inflammation in general. High fructose corn syrup, if you practice in the States, it's often added to the tube feeds. It's a horrible thing altogether. That's just my personal opinion, because it increases glucose intolerance, it promotes tumor growth, it decreases the amount of bacteria that produces butyrate, but you often see it in tube feeds for what reason I don't quite understand. And basically, overall, why this is relevant is when they looked at the composition of gut microbiome in critically ill patients, some of them had composition of biome that was similar to that obtained from decomposing corpses. So probably not very healthy. Why is it relevant? Well, it facilitates inflammation when people are in a severe dysbiosis, so all of your inflammatory cytokines, they all go up. Also, it increases the amount of reactive oxygen species, so basically it creates more DNA damage and facilitates additional immune activation. It promotes bacterial translocation, so you have more leaky gut and you have all of this pathogenic bacteria going into the bloodstream where they don't belong, which further dysregulates the immune system and causes bacteremia. Well, nosocomial infections, dysbiosis plays a huge role in that. There's studies emerging looking into that as a factor, and some studies were done in mechanically ventilated patients, so they found that certain species of microbiome, which is fungal elements, actually have protective effect against ventilator-associated pneumonia. And they noticed that if you have a lot of gram-negative pathogen in the rectum, it has an independent risk for having bacteremia and gram-negative infections. And the same thing with the VRE colonization and enterococcal domination was linked to increase all-cause infection and even mortality. So the other consequence is something that we think about a lot, but not from that perspective, such as brain dysfunction that manifests as delirium. They looked at various patients in the ED, for example, they measured the microbiome, and they noticed that the more diversity you have, the less risk of delirium in the subsequent ICU admission. There were a bunch of surgical studies on post-op patients. A lot of ortho patients, they isolated specific bacteria that may have a protective effect, bacteria that may have a harmful effect with regards to delirium. And they also noticed that there's a gut microbiota metabolite that decreases the risk of delirium. So this is a literature that's still quite emerging. Other organ system dysfunctions that have been linked to microbiome disbalance, again, Annika mentioned that gut seems to be the motor for multi-organ systems dysfunction by increased gut permeability, which you have endotoxin translocation, you have inflammation, and something like ARDS. When we look at the lung microbiota, if we have intestinal microbes in the lung, it's an independent risk factor for increase in inflammation and damage. So if you have staph and enterococcus, these in your lungs, that is one of the best predictors of ARDS. Similarly, dysbiosis have been linked to kidney injury, liver injury, coagulopathy, various hematological disturbances. And the problem is also not just the ICU, but recovery, because if people have severe dysbiosis, the recovery is also challenging because it can persist for many, many months. And by gut-brain axis, patients have all the psychological morbidity after the ICU stay. We never look whether it's their dysbiosis that contributes it, which is have a lot of negative studies, myself being an author on one of them, if you stay here till Friday. But basically, we don't know the mechanism, and that could be one of them, the gut-brain axis. Same with cardiac problems, with the inflammatory conditions, with chronic diseases. So what are perhaps the next steps? Well, I feel that microbiome should be considered as an organ system in the ICU just because of how it is linked to everything else. And any future trial of ICU interventions, really we should be measuring microbiome. We should be looking at the bacterial diversity and the kind of bacteria that are present and how our interventions impact it and what outcome it has down the road. Same way, the recovery process. Can we be measuring microbiome following the ICU stay? Can we be doing something to modulate it in patients with post-ICU syndrome? Are there options available, like high fermented food diet that's been shown to actually restore gut microbiome? Probiotics, not so much in post-ICU patients, but fermented food diet has shown some effect. So potentially, this is kind of where things might be going. So just as a take-home points, as a summary, just think that microbiome and its output touch a lot of pathways that affect our health, disease processing, aging, recovery from disease, and that decreased microbiome diversity is linked with chronic diseases. It falls rapidly after the ICU admission, and a lot of our practice interventions further affect that diversity and not have been designed with gut microbiome in mind, because most of the trials have come before any of this even became known. So perhaps the imbalance of gut microbiome contributes to the inflammation that people have and to the organ dysfunction and nosocomial infections. So perhaps it should be considered an organ system in the critically ill going forward. Thank you all so much for being here and for your attention.
Thank you. Questions from the audience? Yes, sir. There's a mic coming.
Thanks very much for the nice presentation. Based on what you described, loss of organ dysfunction from an upset microbiome, I'm just thinking about my patients on the intensive care who are infection-free and in the convalescence phase. Shall I all give them some Yakult or Activia, or give them even some prebiotics to help to speed up their recovery? So what would you recommend?
Well, you could give them kefir, for example. It has 16 bacterial strains if you get the right one. So it's not one or two strains, it's basically a lot more. So I would recommend to try something that's relatively benign, that is food-based, not pill-based. So, because kind of like with the vitamins, if you eat an orange versus if you take a vitamin C pill, you'll have a lot more bioavailability in the orange. The same way when you eat a probiotic fermented food, you will have a lot more power in the amount of bacteria that restore the gut bacteria. There have been studies out of Stanford by Vastuk and company in 2021 published in Cell, and they compared high fermented food diet with high fiber diet, and in high fiber diet they didn't find any restoration of gut microbiome diversity or inflammatory marker signal, but in the fermented food diet they noticed significant drop in inflammatory markers across the board and incredible increase in the bacterial microbiome richness. So that's your sauerkraut, your pickles, your kimchi, your kombucha, your fermented dairy products, basically all the things we used to eat before the food became pasteurized.
Super, thank you. So another question. Is there an intercontinental difference in microbiome? As in, like, people who live in different parts of the world, they will have different microbiome. And would that have any clinical effect in terms of susceptibility for infection?
Yeah, if you look at people in a third world country, they're not really as susceptible to our usual infections and chronic illnesses as people in the industrialized society.
Super, thank you.
Thanks so much. That was a great talk. Thank you. Our last speaker is Julia Wendon from King's College London. Thank you.
So I'm impressed that anyone's here this late on the first day, especially when there's probably that thought of fermented beer or other alcohol coming down the road towards you. I wonder whether that counts. It probably doesn't. You're going to have to move from the gut to the right upper quadrant, and I'm going to speak about chronic liver disease and the acute-on-chronic liver failure that you might see on your ITUs. I have no declarations of interest. So you end up, whatever the cause, with a stiff liver, with scarring. You develop portal hypertension such that a large proportion of your blood volume is below your diaphragm rather than above your diaphragm, and that results in ongoing organ dysfunction as your liver disease progresses, along with activation of your sympathetic nervous system. What's interesting in terms of acute-on-chronic liver failure is it didn't exist 10 years ago. We didn't describe it, we didn't define it. We probably just called them critically ill cirrhotics. There was someone with chronic liver disease who ended up on ITU with multiple organ failure. The CLIF Consortium undertook to change that and define it based on the SOFA score, and you see that as described here, both in terms of the points based on bilirubin, renal function slightly different to SOFA. Instead of GCS, they used hepatic encephalopathy. This is a GCS less than 7 to 8. Coagulation parameters, INR rather than platelets, vasopressors as previously, and FiO2. And that allowed you to define ACLF 1, 2, and 3. Does it help? Well, yes, it allows us to define it. It's resulted in vast publications. Are we seeing an improvement in outcome? Possibly. And I just want to now go through some of the management of acute-on-chronic liver failure that perhaps has changed in recent years. One thing that is important to say is this is a Western European, USA model. The Asian definitions include fatty liver, rather than necessarily cirrhotic liver, someone who's just got fibrosis that you will see in your ITU who goes very jaundiced. Multi-drug resistant infections are a really big issue in this cohort of patients, probably because they come in and out of our hospitals repeatedly. And as we've heard in the earlier talks, we give them PPIs, we give them antibiotics because they look inflamed. Whether they're infected is a moot point. But multi-drug resistance is a really big issue, and you need to think about it in terms of the management because you see, as would be predicted, your mortality is much higher if you're colonized and then infected with a multi-drug resistant organism. Their hemodynamics are very similar to anyone else with septic shock. They are often volume depleted, but there are a small proportion that develop portopulmonary hypertension. So that's pulmonary hypertension in association with their cirrhosis. There is another group that get right heart failure with venous overload. They're another subgroup. They probably contribute about 20% of the population, and it's the indication for echo in this total population at admission. The rest, you need to give a suitable amount of volume, and I'm not going to say what that should be, though I'm going to touch on albumin later. And then they need vasopressors. They rarely need inotropes, but they will all have a degree of diastolic dysfunction. And it's interesting that that is increasingly associated with other complications. Does it matter whether you get your terlipressin or your norepinephrine first? Probably not. And they probably need to be instituted as soon as you've got a bit of volume in, but without volume overloading them. But it is worth noticing here, and this comes back later when we talk about terlipressin and albumin, that the terlipressin group in this study had a significantly higher incidence of side effects. And they were a mixture of respiratory, gut failure, and possible ischemia that you see with that vasopressin agents. So what about albumin? Because anyone with liver disease gets albumin. This is the Attire study from Alistair O'Brien's group in North London. And they gave one group albumin to keep their albumin above 30. The other group was standard of care. These were 6 cirrhotics coming into hospital, and a good proportion ended up in ITU. You can see that there was no difference in terms of mortality. So early prophylactic administration of albumin doesn't seem to be efficacious. And similarly, it isn't efficacious in the hyponatremic cohort, either in this analysis. But what was seen in the albumin group was more pleural effusions, more pulmonary edema, and adverse outcomes related to the respiratory system. And that, I'm afraid, is going to become a feature of the next few slides that I show you. So Indian colleagues did a really nice study comparing 5% albumin with crystalloid, and they clearly showed a benefit to being resuscitated with your cirrhotic with septic shock using albumin versus saline. What's interesting is the drivers were gender, difficult to explain, but also the severity of your illness. And this study was quite short-term. It was just 3 hours. But this would suggest that early 5% albumin was useful. They then did a 20% albumin versus plasmolite study, similar design, no difference in mortality between these two groups, no difference in vasopressor dose, no difference in renal replacement therapy, much more volume given in the plasmolite group. But what was interesting was the respiratory complications in the albumin group, which resulted in crossover in a significant proportion of patients. So this respiratory failure keeps on coming through. And this is also seen by the work of Wong et al., looking at the treatment of hepatorenal failure using terlipressin and albumin. Now, without question, it reverses your hepatorenal syndrome. So clinical success, significant. Hepatorenal failure reversal, significant. Again, significant renal replacement therapy. But you see the complications here, which again are really significant and come out in terms of respiratory failure and pulmonary edema. That in the UK led to an alert from our drug authority, the MHRA, which basically said, avoid terlipressin in those with advanced renal dysfunction and avoid terlipressin in those with severe liver disease, ACLF grade 3. Now, in all honesty, that's what most of us treat in our ICUs. So I think we just need to be a bit cautious with this drug, and particularly when you're combining it with albumin. What's going to determine your outcome from hepatorenal syndrome? Well, it's early intervention. The earlier, the better. That you get a blood pressure response, and indeed norepinephrine is probably just as efficacious. Again, the severity of your liver disease, earlier rather than later, and whether you can reverse the trigger. And again, diastolic dysfunction is bad news. So these patients are fascinating. They are wonderfully inflamed as a peripheral phenotype in terms of neutrophil lymphocytes. But if you actually look at their HLA-DR, they are immunoparesed, and they really cannot phagocytose and kill bacteria. So you have an inflamed phenotype, which is phenomenally at risk of infection and sepsis. Can we do anything about that? Well, certainly in terms of inflammatory phenotype, again, targeted albumin infusions did not improve things in terms of inflammation or cardiovascular function. This is, again, a predefined subgroup analysis of the Attire study. Interestingly, however, beta blockers do look to be beneficial. So non-selective beta blockers, if you're on them at the time of admission to ITU, they seem to improve your inflammatory profile, decreased white cell count, and a lower CRP. So a reason perhaps to keep them going if one can. I always enjoy confusing receptors. I have no greater logic than that to tell you about using beta blockers and pressors. But those who have had beta blockers seem to do well. Hepatic encephalopathy, you've got to protect the airway. These patients microaspirate, and giving them haloperidol or other sedatives in order to try and make them controllable just results in aspiration and chest infections, and it's a losing battle. So please try and think about early management of the airway. It can progress very rapidly. Acute-on-chronics are not at risk of cerebral edema. This is a big difference between acute liver failure and acute-on-chronic liver failure. So that brain swelling is not clinically important in this group. Sodium and inflammation are definitely contributory, and that shift in sodium and shift in ammonia is a bad mixture in terms of slow to wake up neurology. But just because someone doesn't wake up for 7 days in this disease does not mean they're not going to do well. They need to be given time. It's usually about 7 days that I'll think of popping them through a CT scanner, and about 10 days that they'll go through an MR scanner. Alcoholic hepatitis, it's a nasty disease, and it's growing certainly in our practice. How can you prognosticate it? Well, you can use the Lille score, and you can use the Glasgow Alcoholic Hepatitis Score, or you can use the Madry criteria. I use Glasgow because I come from the UK. You can use whichever you like. They're quite similar. They all work well. Steroids do seem to work for a subgroup, as you can see here, with a Glasgow's cutoff of 9. But what's important for us, sorry, I've left a slide out, but never mind, is when we've got these patients in our ITU, when should we think about saying enough is enough? This was a study from Gusto et al., 2016, quite old now. And as you can see, it suggested that when you've got 3-organ failure, ACLF3, you're really not going to do well. And maybe you should be stopping. That was the message that came out of this paper. Sorry, this is where it's got to. Alcoholic hepatitis does worse as an acute-on-chronic than non-alcoholic hepatitis. So they do worse. But I would put to you that futility is really difficult to predict. And you can see here that a lot of this depends on what you're admitted with. And if you looked at ACLF on admission, 3, then you've still got a 20% survival. That's really difficult for me anyway to call futility. So we need to think about this in a bit more depth. And that this is really old data from our unit now, but it shows, for me, the most important thing is that over time, your outcome improves. And this was despite the severity of the illness changing. So these patients, over time, small little nudges, nothing clever, actually improves things. What else impacts outcome? Well, sarcopenia. So if you've got someone bright yellow with multiple organ failure who's got no muscle mass, can't get out of bed, been in the wards before they come into your ITU, not been mobilizing, the odds are that's a poor prognostic factor that's not in any of the models at the moment. You can use a Cliff C-score, and that is said that if you've got a score of greater than 70 at day 3 post-ITU admission, then indeed it's a reasonable specificity. Sensitivity is still not that great, however, but probably a little bit better. This is some work from my colleagues at King's, looking at the difference between if you come in ACLF grade 2 and you get better by day 3 to 7, you do really well. If you get worse, you've only got about a 15% survival. If you come in with ACLF grade 3 and get better, you're doing pretty well. You've got a window for recovery and transplant assessment. If you stay in grade 3, then again, your survival is less good. But it's not 100% mortality. And so I would suggest to you that we need to think about transplanting this cohort of patients earlier and perhaps being more aggressive in our thought processes. This is some data now looking at survival rates. Given time, I'm going to draw your attention to this slide, which is the survival for ACLF based on grade. You're looking at a 90%, 88% survival at post-transplant. It's a lot better than 20%. So we need to be more aggressive. The same for alcoholic hepatitis. This is the work of French colleagues, Louveau et al., and Belgian colleagues, really impressive data. I'm going to just skip through that. You can use the SALT score to try and predict who you should transplant from ITU, and that can give you a mortality predictor and a length of stay predictor. You can similarly use the TAM score, much simpler. Lactate, ventilated with an FiO2 ratio of less than 200, age, white cell count, giving you a TAM score here, which is useful to determine who should be transplanted. So, Chairman, ladies and gentlemen, I think the liver is not evil and it should not be punished. Indeed, we should exercise it within moderation. But importantly, I think, consider albumin. I'm not saying it's wrong to give it. I give it sometimes, but don't use it excessively and be careful when you're using it with terlipressin. Monitor your patients and think about transplantation. Thank you for your attention.
Thank you. We'll take a question. Yeah, see right over there. We have one question.
Hi. So there is a lot of differences in the uses. Which pressors do you use? Terlipressin and so on and so forth. What is your take on replacing terlipressin with vasopressin? It's easier, simpler. We're used to it. It's just so much better. And also, it has been our experience that sometimes terlipressin can have very severe adverse reactions, especially cutaneous reactions. We've had a few very bad cases, which doesn't seem to be the case with vasopressin, which we use so much more in sepsis, and we seldom see those types of reactions. So do you think that we could just leave terlipressin alone and work with vasopressin?
Personally, that would be my intention, except in the context of acute variceal bleeding, where it probably does have a role initially. Because it can be used in the community, which vasopressin can't be, and that has a benefit, or in the emergency department as a first bolus. I only ever give 1 milligram, never 2 milligrams, and usually 0.5. My day-to-day practice would be vasopressin rather than terlipressin, and I'm old enough to remember when we gave vasopressin for variceal bleeding many years ago, we always used to give it with GTN in order to mitigate that ischemia. But I think you're right, there's something about the bolus effect, that the ischemia that you can see cutaneously, cardiac also, is significant and shouldn't be ignored.
Sorry, what do you think about the use of the therapeutic plasma change in ACLF?
So ACLF, the big study is from the Cliff Group, is completing and analysing at the moment. The data from Indian colleagues would suggest that it's useful in a subgroup. For me, acute-on-chronic is a bit too broad, and I think in alcoholic hepatitis it might have a role, but I think what we've really got to be careful with in our acute-on-chronic cohort is not giving it when you're immune-paresed. Because if we learn anything from the acute liver failure data, is if you give it too late, it worsens outcome, or certainly doesn't improve it. If you give it early, it's really beneficial. So I think timing is everything, like cooking a souffle. Timing is everything.
Mm-hmm. And with that, we'll leave it. Timing is everything. Thank you so much. Thanks, everyone, for staying late.